Hello, everybody. It's really a pleasure for me being here today and share this very interesting webinar with the title COVID-19 in the Gaza Strip, a role for social science in humanitarian action. Now, what I believe makes this webinar extremely relevant is, among the other things, why it's very good, is the case study with the Gaza Strip. Now, as you may know, 2 million Palestinians live within less than 400 square kilometers in the besieged Gaza Strip, making it one of the most densely populated places in the world. Of this population, 1.3 million are refugees, and over a third of the total population remain internally displaced following the Israeli military operations. This webinar presents research conducted in Gaza from July to December 2020 on community perspectives across the Gaza Strip on dealing with COVID-19 in a context of protracted displacement, prolonged conflict, and blockade. Drawing on ethnographic research with youth around Gaza, the study addresses the ways communities have negotiated public health measures in Gaza and the socioeconomic impact of public health measures within communities. So what makes Gaza extremely relevant today is that it affords us with a better insight into one of the main policy approaches to address the challenges of modern times, which is immobility. Now, may this be the challenge of irregular migration, maybe the spreading of a virus, enforcing immobility through lockdowns, border controls, etc., etc. It seems to be the solution for a better world. Empirical insight systematically challenges this truth, and so it will, I believe, today, this webinar. But before giving the floor to Kathleen and Mohammed, let me spend a few words on the speakers. Kathleen Proctor is a part-time professor, jointly between the Migration Policy Center, the Department of Social and Political Sciences at the European University Institute. Kathleen is an ethnographer, and her work focuses on youth in context of political violence, forced displacement, and irregular migration. She has conducted extensive fieldwork in Palestine, Lebanon, and Jordan. She has earned her PhD in International Development from the University of Oxford in 2019 and was a Max Weber postdoctoral fellow at the UI from 2019 to 2020. She's also held visiting fellowships at Harvard University and the University of Birzeit in Palestine. Kathleen's first book on the politics of mobility among Palestinian refugee youth in East Jerusalem is currently under review, and she's preparing a second manuscript on youth and irregular migration from Gaza. Mohammed Rozzi is a research associate at the University of Bath. He earned his PhD in social anthropology from the University of Fribourg, Switzerland, and his master's degrees in childhood studies from the University of Edinburgh. He has authored book chapters and articles on child-related topics, including education and foreign aid, child labor, residential care, and child detention. Arozzi has worked with many international governmental organizations and UN agencies, including the Norwegian Refugee Council, World Vision, and UNICEF in the Middle East. Now, let me give the floor to the speakers. So, Kathleen, I think the floor is yours.
Great, Luigi, thank you so much for that warm introduction, and huge thanks to Andrew and the Migration Policy Centre for inviting us to give this webinar today. I'm just going to share my screen. Okay, so I will start by discussing some of the background and context to a study that we conducted together, myself, Mohammed, Luigi, and a number of other colleagues last year, that's on community perspectives to the pandemic in the Gaza Strip. You should have a link available in the channel to download the study. It came out in January of this year. And the study was led by Dr. Jason Hart at the University of Bath, and it was funded by ELRA under their Research for Health in Humanitarian Crises funding stream. Everybody who was working on this team of this study has a lot of experience doing research either in Palestine or with Palestinian communities that have been forcibly displaced around the region. And then other members of our team, notably Dr. Louisa Enria, who's from the London School of Hygiene and Tropical Medicine, also has experience as an anthropologist but working on other public health crises in humanitarian settings, most notably the Ebola response in Sierra Leone. And it was really sort of building on this body of ethnographic work that came after the Ebola response that we saw the importance of having a good understanding of community perspectives at the start of a pandemic in order to ensure that there would be community buy-in and community buy-in to public health measures as they were rolled out. So among our members of this team at the start of the COVID pandemic last year, we started wondering, how would COVID manifest in a place like Gaza, in a place that's extremely overcrowded, inaccessible, and most importantly, a place that's under blockade. And so with that in mind, we developed this study to really look at community perspectives that were evolving throughout the pandemic and to try and bring those community perspectives to the fore in the early stages of the formulation of the humanitarian response. So we were looking at questions of trusted sources of information, the spread of rumors in relation to COVID, the uptake of public health measures to the extent that that was possible, and then starting to explore some of the social and economic impacts of those public health measures. But really, what we want to discuss in this webinar more broadly today is to have a look at the intersection of health and protection and mobility, or in the case of Gaza, immobility, in the context of COVID-19. So I'd like to start by just taking a quick step back, because indeed all of our findings, as Mohammed will discuss shortly, take us back somehow to this context of immobility that has defined the lives or the everyday lives of Palestinians living in Gaza since the blockade began in 2007. And if we look at Palestine more broadly, Palestine has been characterized by different kinds of forced mobility or forced immobility, dating back to the Nakba of 1948 and the creation of the Israeli state, which led to the forced displacement of more than 700,000 Palestinians, to refugee camps both in the West Bank and Gaza, but also elsewhere around the region, and refugee camps which are still there to this day. Then combining that with the Israeli military occupation of the West Bank and Gaza, which began in 1967, and has really fundamentally controlled and policed the mobility of Palestinians both in and out of the West Bank and the Gaza Strip. And then to add to that, the context of the Israeli-Egyptian blockades, which has been in place in Gaza since 2007, since the election of Hamas. Now, this map on the left, I appreciate that the text is quite small, but we wanted to just illustrate and be really clear that the blockade of Gaza is not only a blockade of land, but this blockade also extends to the sea. So Palestinians can only travel up to 6 nautical miles off the coast of the Gaza Strip, and in reality, that distance is regularly much smaller than that. And then in the context of Gaza itself, there are just 2 crossing points for people to go in and out of Gaza. We have the Erez crossing here in the north and the Rafah crossing here in the south. Both of these crossings are extremely highly controlled and policed and very difficult to travel across. And the reality is that the vast majority of Palestinians who live in Gaza have not been able to leave since the blockade began in 2007. And that means, in fact, now in 2021, we have a whole generation of young people who have grown up in this context of blockade. Now, as Luigi already explained, the land of the Gaza Strip is very small, just 365 square kilometers, and home to a population of 1.9 million. That makes Gaza one of the most densely populated places in the world, and it's colloquially referred to as the largest open-air prison in the world as well. So in such a context, you can imagine social distancing becomes something of an impossibility. Now, this is important to really reflect on the parameters of immobility in Gaza, because as the rest of the world as we were all coming to grips with what immobility meant in the context of COVID, when this came to dominate so much of our lives last year, in Gaza, people have been living without freedom of movement for 14 years now, and that changes the ways that people think about coping strategies and possible responses to the pandemic. So just to highlight 3 very quick examples of how the blockade has really impacted on the ability of Palestinians in Gaza to respond to COVID-19. We've already talked about how the blockade limits the freedom of movement of people. It also limits the freedom of movement of goods. And that also extends to medical supplies and to the ability of patients who are in need of acute medical care to be transferred to hospitals elsewhere. So just to give you an idea, at the beginning of COVID last year, there were just 65 ventilators available in the whole of the Gaza Strip. Another way that the blockade has limited the ability to respond to COVID in Gaza is that it's fundamentally undermined health and sanitation for a long time in the Gaza Strip. There are severe limits on access to electricity, and there's been severe damage done to sewage treatment facilities and desalination plants, meaning that while we've already discussed it's very difficult to socially distance in Gaza, it's also very difficult to access clean water. So these are two of the very basic tenets of a public health response to COVID, as we've seen implemented elsewhere. And then finally, the blockade has really fundamentally debased the Palestinian economy in Gaza, to the extent that now only 40% of the working age population 40% of the working age population are unemployed. And of those who are employed, the vast majority work on the basis of daily wage labor. So again, these are all things that when we go into the findings of this study with Mohammed shortly, these are all things that have huge implications for the rollout of the public health response. Now, in our study, we relied on qualitative methods to explore the kinds of themes we were interested in. And because of the evolving nature of COVID at the time that we were doing this research, we decided to do this research entirely remotely and in partnership with the Tamer Institute for Community Education, which is in Gaza City. So really our purpose was to try and see how the pandemic and the associated regulations were affecting the economic and social, but also psychosocial well-being of the population and how that was evolving on a daily basis. So you can see here on the left our research locations where we were able to do work across the Gaza Strip. And the three primary methods we used. So firstly, we did a diary exercise with young people, and this was primarily designed as a way of bringing young people's voices and perspectives into the study, but also drawing from ethnography. It was really a way to try and capture some of the complexities of daily life as the pandemic was evolving. We coupled this with 40 semi-structured interviews and then trialed a new research method of using WhatsApp voice notes, whereby we would send questions by voice note, but then people could respond to those questions at a time that was convenient to them. And that was sort of designed with the parameters of COVID and everybody having lots of people in the same household at the same time. And we can go and talk a little more about methods later if that's of interest. But just before I hand over to Mohammed, I just wanted to locate you a little bit with what the with how COVID was progressing at the time that we were doing this research. And then I know our colleague Ashraf is going to bring us up to date later on in the webinar today with how the situation has evolved since then. But what you can see on from this graph overall is figures of total cases during the study period. So this was from September to December. And so as you can see, by mid-December, when we concluded the study, there were a total of 28,500 cases of COVID in Gaza. What you can also see along the bottom here is just a timeline of where we were doing the different aspects of our data collection. And just to spend a moment to say that this progression may seem quite slow, but that's because community transmission started quite late actually in Gaza. It wasn't until mid-August of last year that the first case of community transmission was discovered in one of the refugee camp communities in the Gaza Strip. And before that, the authorities had done a very good job of keeping COVID out of Gaza. However, fast forward to the situation today, and we can see how dramatically this has escalated to the point that there are now there've now been a total of over 73,000 cases of COVID in the Gaza Strip. And actually, the news of today from the Ministry of Health is that just today, the highest infection rate in 24 hours has been reported at a rate of 1,916 cases. So a rapidly escalating or continuing situation in Gaza. So let me hand over now to my colleague Mohammed, who's going to take us through some of the findings of our study. Thank you.
Thanks, Kathleen. Thanks, Luigi, for the warm introduction, and thanks for our audience for joining us today. What I'm going to do in this short presentation, I was giving just 10 minutes to summarize the study we've been working on for 6 months or more, but I'll try to be brief and bring the key aspects of our research to you here in this presentation. So first of all, I'd like to give you an idea about the structure of our research, which captured 4 different themes. And you can see these themes at the bottom of this slide. So we have the sources of information. And as part of this theme, we were looking at the circulation of information, rumors, fake news, and different kind of information among the research participants and communities in general. The second theme was about access to healthcare. And here we were speaking about access to healthcare for those who were infected with COVID-19 and those who are feeling sick for other reasons, like for other illnesses. And the third of these themes was about the impact of these regulations and enforcement of this kind of regulation on the population. And the last one is about how the community reacts to these regulations, where they welcomed, where they criticized, what extent people were find them useful or contradictory or confusing. And this is part of the questions we're going to tackle as part of this presentation. So as part of the first theme of this research, which was about the sources of information, we were seeking to understand how sources of information are most trusted within the communities and the prevalence of rumors circulating in relation to the virus. And what we found out that almost all of the participants in the study prefer to communicate through the social media, especially Facebook and Telegram. And this was their primary source of information, especially through the channels which are affiliated to official bodies, for example, Ministry of Health or Ministry of Interior Affairs or WHO. And they were preferring this rather than relying on traditional news outlets, like, for example, press conferences and briefings, which were never kind of relied on as part of this, as part of dealing with the information management of this crisis. And as part of this aspect, we can see there were some kind of variations between men and women. So for example, men tended to seek information from personal connections, for example, doctors and nurses who are working inside hospitals, or journalists because they have an early access or recent access to the developments of the pandemic, while at the same time, women were relying and were kind of triangulating their information from different sources, relying partially on the social media outlets, but at the same time, triangulating this information through family connections and friends. And what we found out as part of this research that although there was a good understanding about the threat of the virus, there were many reported general skepticism about the source of the virus, where it come from, and they were kind of doubting the response to that virus. And one of the quotations which captured this, which you can see now on the screen, and it's for a girl whose age is 17, and she said, as part of a diary entry, someone told me that the virus is spread through mosquito bites. Since that day, I stopped opening windows or doors, fearing that a single mosquito would get inside. I sometimes missed fresh air and sunshine, but there was no way that I would open windows and doors. So I think this kind of quotation captured the level of how the information were kind of circulated inside the community and the fears of the young people as well, which we managed to capture, as Kathleen said, so the diary's entries. So moving to the next aspect of our research, which was about access to the healthcare. And as part of this, we were looking at, for example, to what extent the behavior of the population has changed since the pandemic in seeking health service or seeking health care. And as part of this, it's very important to mention that the official guidance on what to do in case of infected with COVID-19 coming from the Ministry of Health has been changing across time in the Gaza Strip. So initially, government designated some areas where they were keeping people who were infected or who were tested positive, but this has changed. This policy has changed recently. And the policy which is currently in place is that whoever gets infected has to stay at home. The problem is that sometimes there's a lack of trust between the citizens or the population and the government. So the government sometimes has to station some policemen on the doors of the people who have been infected. And this is, in fact, is critical for our community perspective, because the consequences was that many of the respondents reported that people often avoid to report being infected or having suspicions about being infected about COVID-19. And this is, in fact, make them kind of a carrier in a way or another to the virus amongst their communities. And one of the aspects which we covered as part of this of that research is that respondents also give examples about health workers or healthcare workers who were kind of avoiding to treat patients due to fear of being infected. They were fearful of being infected, and because the healthcare structure weren't sure about to what extent the pandemic is widespread in Gaza, because many people were hiding the fact that they have symptoms or they have been infected. And another aspect of this was about the stigma. So the study also found that concern about stigma discouraged people from seeking treatment. At the inception of the pandemic in Gaza, the Ministry of Health published the names of the individuals who have been contracted the virus, and this encouraged or discouraged people actually from reporting that they have symptoms. Although this practice is no longer in place, but it affected the way the people are reacting to this kind of development. Can we move to the next slide, Kathleen? Thank you. Now, these kind of regulation have impacted the population dramatically, and we can see this across the study which we have conducted, and it affected them, for example, psychologically. It affects the social fabrics, for example, it affects their economic situation, it affects being in debt. And in this short presentation, I'm going to give just a glimpse of idea about how people see this regulation to be affecting them. So first of all, one of the aspects which was reported as part of this study is that a big number of people were relying on debt. Actually, debts were widely cited as the only way to survive the current situation, and this is exacerbating a problem which was already there in Gaza for many years now. The fact that many of the population in Gaza are dependent on debts which are taken sometimes from the family or from the supermarket or from social connections to overcome the high level of poverty and unemployment in Gaza. So we have to imagine what does this mean in the presence of the pandemic and with the increased level of unemployment overall the population in Gaza. And another aspect that we captured as part of this study was about the anxieties and depressions, which were also reported, and especially among young people who lost connection with their educational setting, with their colleagues, with their kind of social networks, which were reported in many occasions in the interviews which we have conducted, but also in the diaries which we have collected as part of this research. Relevant to this is the fact that many of the female participants reported an increased level of violence at the level of the nuclear family, but also at the level of the neighborhood. And while this is perhaps something to be expected and is in line with the global increase of the gender-based violence as a result of this pandemic, what has been reported to be lacking is channels of support for those women who are under this kind of circumstances. And only just in one of the participants, only one participant reported being aware of some of these services which are provided in the community through a toll-free number. But most of the participants weren't aware of these kind of channels to be available. Another aspect which impacted people's life and have been reported vividly as part of this research is the border closure. And here we are speaking about Rafah and Beit Hanun crossing points, and we are speaking about the Israeli tightened restrictions on the freedom of movement, which prevented medical equipment from entry, but also prevented patients who are in critical conditions to receive medical care outside of Gaza. And these have major repercussions on the management of the situation and the pandemic in Gaza right now. And of course, these kind of regulations which were put in place received many reactions from the community, which takes us to the last aspect of our research. As part of this part, we were looking at the community reaction being, for example, in a form of criticism or being in a form of like resistance to these regulations which were put in place. And what we found out that most of the people were okay with imposing more restrictions because they were scared of the virus or contracting the virus, but at the same time, they totally understand that people need to break these rules in order to overcome the insecure economic situations. So in a way, we had this kind of like contradictory messages that we received from our research participants. Some of them were saying, yeah, we have to enforce more of these strict regulations, but at the same time, we do understand when people break rules because this is the only way to provide to the family and to put food on the table. And speaking about the main actors, we were asking the participants about, for example, the civil society organizations, the government, to what extent they were active in managing the current situation. And many of them were kind of reflecting on the work of the civil society organizations who were active in providing, for example, masks and other kind of protective materials, and kind of helping the community to survive this kind of difficult situation of the pandemic. And then when they were asked about the role of the government, for example, in managing the situation, in our attempt to evaluate this kind of response and to share with the government also some of the key messages about this, about how the community perceived these interventions, many respondents were critical, in fact, about the government's role for not putting enough kind of enforcement of regulation for the public health measures. And many of them were accusing the government sometimes of the mismanagement of the response and for the illogical decision-making processes which take place across the pandemic. So, for example, many of the participants were reporting that we were not allowed to go to the mosque during Ramadan, which is an important occasions for people to go to the mosque and to celebrate the holy month. But at the same time, public markets were open to the public, which create confusing messages to the audience and to the population. And another example, which was reported as part of our study, that restaurants where social distancing can be possible were closed and weren't allowed to operate. But at the same time, food street where tens of people are collected all together without any precautions for health. Those kind of small businesses were allowed to operate at some point. I think the situation is still evolving, and the fact that today we recorded, in the last 24 hours, we recorded the highest number of infection per day since the beginning of the pandemic is quite telling about the situation. These findings were reported by December of the last year. I'm sure there were many updates, and we'll appreciate also hearing from Ashraf and colleagues about the new developments since then. I think this is all for now. I'll be happy to elaborate and to reflect on more of these aspects later as part of the discussion and in the Q&A section. Back to you, Luigi. Thank you.
Thanks, Mohammed. Thanks, Kathleen. I think now it's the time for the discussants to express their opinion and listen what they think about the findings of this research. So the first of the discussants will be Diane Duclos. Diane Duclos, she is assistant professor at the London School of Hygiene and Tropical Medicine. She is an anthropologist with more than 10 years experience conducting ethnographic research with displaced communities in the Middle East, investigating refugees' transnational strategies to move, secure livelihoods, and access health services in chronic crisis. Some of Diane's recent work include a study looking at the role of Syrian clinicians in the delivery of cross-border humanitarian assistance from Turkey to northwest Syria. A study examining the concept of culturally appropriate care for refugees through the practice of Syrian displaced health providers in Lebanon, and a policy brief on COVID-19 in the context of forced migration for the Social Science and Humanitarian Action Platform, which highlighted the role of refugee-led organizations in mounting responses to mitigate the health and economic threats posed by the pandemic. Diane, I will leave the floor to you, and after your presentation, your discussion will introduce Ashraf. Thank you.
Thank you very much. I think Ashraf was supposed to go next, but I'm happy to talk now if it makes sense. Yeah, okay. So Ashraf will go next with an update on the situation in Palestine. So thank you so much for the introduction, Luigi, and thank you very much to the Migration Policy Center for the opportunity to join the conversation today. So I've been asked to step back and broaden up a bit the discussion to think about how COVID-19 affects the lives of forcibly displaced communities. I really think that the study presented just now by Kathleen and Mohammed is a really important contribution to really understand how COVID-19 is affected the life of communities in a context of protracted or chronic crisis. This contribution really offers empirical insights into the perceptions, the experiences, and the everyday strategies developed to cope with the spread of COVID-19 and also to cope with the public health measures which have been implemented. I think also what is really fascinating through this study is that they really also successfully locate these experiences, these strategies in longer term experiences of living under siege. And somehow the picture of the epidemic in Gaza, which is painting through these findings, really challenge a narrative which has been, I would say, really dominant over the last year, which is the narrative of COVID-19 as this really unique, disruptive moment. And interestingly, the shifts they just, I think, somehow offered now in framing the pandemic, not only as through the lens of public health, but also considering political, economic, and protection dimensions, is really critical to understand the vulnerabilities of forcibly displaced populations in the pandemic. And when I talk about forcibly displaced people, I mean refugees, internally displaced communities, but also increasingly returnees. So when we initially discussed the structure of the webinar with Mohammed, Kathleen, and Ashraf, we got particularly interested in addressing how simultaneous processes of forced displacement and forced or enforced immobility can shed light on each other through the lens of COVID-19. And Kathleen started to make us think through this question. So rather than focusing on vulnerabilities to the virus, I will put in conversation ideas of forced immobility related to the blockade in Gaza and to COVID-19 lockdown measures with long-term processes of mobility in the region. So for this discussion, I mainly draw on the policy brief Luigi just mentioned, which was produced for the Social Science and Humanitarian Action Platform, which I led with my colleague Jennifer Palmer, and we did this work earlier in the pandemic last year. And this policy brief was looking specifically at the impact of COVID-19 for forcibly displaced population. And my work was mainly working with organizations and communities within the Middle East. So I do realize that the discussion points I will go through may raise more questions than provide actual answers, but I really hope that it will trigger perspective maybe from some of you listening in today who may be involved in delivering responses on COVID-19 or in the context of COVID-19. All right, so let me start by speaking about how COVID-19 is threatening coping systems that forcibly displaced communities have been building over long periods of time in a quest for security and protection and also to secure livelihoods. So here again, I want to also draw on the work that has been presented now by Kathleen and Mohammed to think about a bit across and beyond this disruption moment of the pandemic. And we know that entrenched conflicts and post-colonial legacies have profoundly shaped patterns of mobility in the Middle East over generations. And this is affecting coping strategies of people who decide to leave, but also of people who stay, of people who are internally displaced and those who cross international borders. And we know that during wartime, the ability to move is key for populations' quest for survival and security. And to cope with economic insecurity of war and forced displacement, people tend to create livelihood mechanisms drawing on a diverse repertoire of coping strategies and transnational income streams. And this repertoire is made of different social networks that can give access to savings and capital, mutual assistance, and education and work opportunities. So I think what I'm trying to say is that what is sometimes referred to as resilience in the humanitarian and development sector, and what Rita Jackaman nicely framed as the capacity to endure and resist, actually encompasses a wide range of strategies which have been developed over time to build and rebuild one's life in adverse situations. And today, what we're seeing is that these social relations and relationships and resources are all being stressed by COVID-19 restrictions. So this new enforcement of immobility in societies which are structured around immobility are having an impact on strategies which have been developed over across generations. So today we see that most displaced people in camps and informal urban settlements, we know that most of them are dependent on daily wages, and Mohammed also talked about that. And they have fewer savings and employment benefits to sustain the shocks of lockdown, restriction and employment. Restrictions on people's ability to secure income from informal, from informal employment. So most of the refugee also communities or displaced communities don't have access to these safety nets that may be available in host countries. And this is also putting more pressure on humanitarian aid and remittances. And these aspects of the financing, also of talking about humanitarian aid and remittances, are also threatened by the financial implication of the pandemic. So we also know that disruptions to education is also having immediate consequences and longer-term implications, which are amplifying inequalities in people's ability to build careers and just plan for the future. Another point I think which I want to raise has also been raised by Mohammed is the increased use of security surveillance resources to enable the crossing of borders, which is also affecting strategies to seek healthcare. So to give you another example of that, we can talk about the border between northwest Syria and Turkey, which has been closed to Syrians seeking refuge in Turkey, if you want, before the pandemic started. But before the pandemic, exceptions had typically been made for patients with critical conditions living in Syria, in northwest Syria. For instance, patients with cancer could cross and seek medical care in Turkey. I'm sorry. However, in March 2020, with lockdown measures implemented in Turkey, we saw this option being closed to Syrians in northwest Syria. And they've been left in a region where health facility had been bombed, where the politics in Syria can make impossible the option to go somewhere else in Syria to seek healthcare. So really, populations of Syrians people, including internally displaced people, are just stranded without access to specialized healthcare. And this is also echoing some of the findings from Palestine and from Gaza. And some of it has been mentioned in relation to the Rafah crossing point. So these are just a few considerations that are illustrating the need to imagine a response to COVID-19 which ensures that displaced populations are not pushed into even more precarious situations by public health measures. However, amidst this sort of insecurity and difficult context, what we've seen since the beginning of the pandemic are responses that have been mounted by local communities, including refugees. So I'm just going to move to this point, trying to account for specific examples of COVID-19 responses led by local communities. And there is a very interesting paper which has been published by Elena Fidian-Kazmieh, who shares accounts of initiatives mounted by residents in Al-Badawi Palestinian camp in Lebanon during the pandemic. And she really depicts how, in the context of the pandemic, many camp residents very quickly identified the risks that existed outside the camp and how they encourage residents to stay home, even before the curfews and lockdown measures were implemented. She also describes how volunteers in Badawi camp have been working extremely responsibly to reach out to all residents, irrespective of their nationality, to provide guidance and support in mitigating the pandemic. And she also alerts us or warns us on the fragilization of these support systems, in particular in a political climate where specific group of refugees are being stigmatized as carriers and spreaders of the disease. There is another example which has been accounted for in a paper published by Abdelkarim Exayez last year, which showed that despite chronic lack of resources, the health system in the northwest of Syria has been building from previous outbreaks, such as the polio outbreak in Syria in 2013, to enable surveillance system for the new pandemic. And he also demonstrates how, this paper demonstrates how social media tools such as WhatsApp were used to collect health information and to communicate public health information messaging. So the COVID-19 pandemic has clearly exposed the leading role of local actors to drive responses on the ground, especially in a context where international humanitarian actors were also constrained by this forced mobility, sometimes operating remotely. So despite the clear role of driven by local responders, despite global commitments to localize humanitarian aid, these initiatives or local actors who led these initiatives are still largely marginalized from disease control decision-making at all levels of the response. So I just want to move to my last point. I'm not sure how am I doing with time. Okay. So we'll just move to my last point, which is about discussing how social science research and ethnographic research, such as the one which has been presented today, can help us inform public health responses which recognize contextual and chronic vulnerabilities, as well as local solidarity mechanisms. Because addressing vulnerability to epidemics in forcibly displaced populations who have witnessed violence, experienced extreme hardship, and already had to rebuild their lives multiple times is obviously a complex task. And the coping systems which populations displaced by war have built up are fragile. And humanitarian responses and public health responses should really take care not to harm these social relationships and networks which populations turn to in time of crisis. And this is also where there is scope for COVID-19 responses to incorporate social science research, to adapt intervention and ensure they reflect the diverse realities and political context of displacement and containment. And the study presented today is an excellent illustration of this. And such approaches will be even more critical in the months and years ahead. 2020 has been the year with the lowest refugee resettlement numbers UNHCR has witnessed in almost 2 decades. And refugees are often left without prospect for durable solutions. For example, in Lebanon, since March 2020, the COVID-19 pandemic has further compounded pre-existing socioeconomic hardships of Syrian refugees and also Lebanese nationals. And a recent report by Refugee Protection Watch shows that while conditions for a safe and dignified return in Syria are clearly not there, COVID-19 and other crises overlapping with COVID-19 are pushing refugees in neighboring countries to return to Syria. So COVID-19 is clearly exposing the limitations of humanitarian protection systems to provide safety and protect livelihoods for population. And this is really why we have a lot to learn from this Gaza study on how to reframe our gaze when building epidemic responses in chronic crisis. I'm going to stop here.
Diane. So very quickly, let me rush through Ashraf. Sorry for skipping you before. Now it's last but not least, it's your turn. Ashraf Abu Musa is M&E officer working at the State Audit Administrative Control Bureau in Palestine, Gaza, providing decision makers with appraisal reports and policy brief on the effectiveness and quality of public organizations' performance. Recently, he participated in conducting policy research on the role of Gaza's government in fighting COVID-19 and currently conducting research for the International Transparency Palestine branch on transparency and anti-corruption activities in Gaza's public organizations. He's a former policy leader fellow at the European University Institute at the School of Transnational Governance in 2019. During this time as TG fellow, he presented and discussed the issue of humanitarian diplomacy in the Middle East. Ashraf has an MA in International Development Policy from the KDI School of Public Policy and Management in South Korea. Thanks, Ashraf. Please leave you the floor.
Okay, thank you for the invitation, and I'm so delighted to be with all of you today. Looking for discussing this very interesting paper, which focused on very complicated research topics in my city. I have read the paper. It is very interesting and have many contributions to our policy research. I will start with the shining light on the situation updates for the period after the study time frame. Now, the average daily infection rates for the last 2 weeks from 24th of March to 6th of April is 1,000 cases. The average weekly infection rate from January to March about 1,800 cases. And most of experts and officials expect that the same pattern will be constant until the 20th of April. Now the total vaccinations exist in Gaza is around 80,000, and only 0.4% of population got the vaccines. Since March this year, the Ministry of Health could discover the new version of COVID-19 spread in Gaza, and then this week again, the government identified the virus transmission hotspots and took the decision to back to the previous emergency measures. And now this week, the government imposed a partial lockdown. It shut down the educational institutions, wedding halls, and popular markets, as well as the morning gathering. So after the study, there has been a dramatic change in the COVID-19 spread or outbreak in Gaza City. I will start with mentioning some dramatic change in the individual perceptions and behavior. As mentioned in the study, that people consider at the beginning of the crisis, consider the virus infection as a stigma. Nowadays, after the increasing number of infected cases inside the society, now the virus infections is no longer a stigma in the community as it was before. After the outbreak of the second wave of the virus, the level of adherence to preventative measures increased than before. You can see many people wear face masks and keep social distancing. Also now, the population are no longer see the measures adopted or needed to manage the pandemic as worse than the disease itself. And that's due to the replacement of the mandatory quarantine in government designated areas by the self-isolation. So it is more easier. It's easier than the mandatory quarantine for people. So also people now have abandoned the belief that COVID-19 can be treated with herbal remedies or hot teas. So these changes has been appeared in the ordinary people behaviors and perceptions. Regarding the study, I do really agree with all findings and recommendations mentioned in this study, and most of people here also agree with that. But I can say that, for example, for the source of information, now the study say that the major source of information about the COVID-19 is extracted from social media. Okay, that's true, but I can argue here that the social media played a negative role in this regard. Now, for example, the circulation of rumors and fake news, whether they are organized or non-organized, actually this rumors have a negative impact on the perception of people and reflected negatively on their behaviors. So For example, you can see daily fake news mentioned in the Facebook and Twitter about the, for example, the number of cases discovered. Sometimes people say that they are 3,000 or 4,000, but in reality, they are less than that. So these rumors affect negatively and then increase the fear level among people. So in this regard, I would suggest that we can expand the investigation and broaden up the debate on the rumors in Palestine and in Gaza, and whether it is connected to the educational and cultural level, and how this intersects with the coping strategy of COVID-19. The other bad or negative image of social media played in the society, that the misleading and confusing statements of official spokesmen. Now, people in Gaza hear contradictory new statements from officials. For example, you can see that officials of Ministry of Health say that we are on risk, the situation is very dangerous, and take care. In contrast, you can see that officials from Ministry of Interior say that no, we have already overcome the virus and the situation is stable. So there was a confusion in the statements of official spokesmen. So in this regard, I can say that we need to broaden up the debate about the digital accountability of officials or actors, like for how the digital technologies, especially social media platforms, alter our perceptions about the accountability of government officials and spokesmen. I can say also that despite the positive role of governments in fighting and combating COVID-19 in Gaza, actually the government did its best, but there were some challenges and problems encountered by the government during the last year and during fighting this virus. The first problem or challenge is that at the beginning of the crisis, when the virus had broken out of the quarantine centers to inside the city, the working medical staff were not well trained to deal with the cases. So this made healthcare workers reluctant to treat patients at the first, and such problem increased people's fear, and thus many people did not get tested or disclose their infections or symptoms. The other problem is the economic stats itself. It was really challenging for government in terms of imposing lockdowns or other public measures. For instance, imposing lockdown without securing the basic needs for those who get their income on a daily basis was difficult. Now, based on other countries' experience, that they merged between coping strategies or public health measures with economic and financial plans, how to force lockdowns without providing the basic needs for people. Now, such decisions needed government support and thus increased the financial burden. So the government was reluctant in this regard, and it really encountered a problem in this. So this was a challenge for the government. And on the other hand, the government was not able to impose fines and penalties on those who were breaking the existing regulations because of their economic status. So we have to understand these calming strategies and adopting public measures in line of economic or socio-economic status of displaced people. Some people also inside the society still believing in conspiracy theories, and some of them also see the virus as the same as the regular flu. So thus they don't follow the regulations and don't see that there is any really necessity to follow the means of protection. So this behavior really represents a major challenge for the government in combating the spread of virus. Education system also has suffered very much from the rapid and sudden transition to e-learning. From traditional education to e-learning, it was difficult because the government took the decision without prior preparation for that. Students were not able to be adapted with the e-learning easily. I can say that more than half students, especially in primary schools, lost or missed the online lessons, and the involvement rate was very low due to the insufficient knowledge of the designated online applications and the lack of some people in rural area don't have the necessary tools or smartphones or laptops or tablet or something like that. So this was really a challenge for students. Also, teachers were not able to deliver lessons easily because of insufficient pre-training. So here the responsibility is for the government, how the government took the decision to transfer to the e-learning without any preparations or prior plans. One of wrong decisions that the government took is that at the beginning of this year, in January, the government made a decision to gradually return to the normal life. So there were many statements from officials that Gaza had overcome the virus, and thank God everything will be okay, and let's back to the normal life. I believe this decision was wrong. It prompted many people during January and February to give up the necessary precautions and did not care about the infection. So this contributed to the increasing in the cases infected later.
Sorry, Ashraf, I'd ask you to conclude, so to leave some time, some space also for the debate. So please go ahead, but just try to sum up your.
Okay, now I have finished, but I want to ask two questions about this research. Now, you know, some ethical considerations may be raised during conducting qualitative research in regions witnessing political upheavals or socio-economic vulnerability that require the existence of safe conditions for research participants by considering ethical aspects into the planned research. I'm wondering, asking the researchers, what are the ethically problematic areas that were addressed by participants during the field work and data analysis, and how did you deal with them? The point is that I'm wondering whether the researchers consider the political affiliation of participants, because you know the political affiliations of one party may maybe reflect on their answers. So if you ask one participant from Hamas, for example, how your government is doing for combating the COVID-19, he will say that our government is doing well, and regardless of the fact that it's not. So on the other hand, if you ask anyone from the opponents of Hamas how the government is doing with the COVID-19, I guess it is difficult for them to say the truth. So how the researchers did manage this problem? That's my comments and questions for researchers. And thank you very much, Kathleen, Muhammad, and other researchers for this interesting paper. And thank you.
Thanks a lot, Ashraf. I would like to remember, we are short of time. I would like to remember everybody who's listening that they can post. It's possible to post if they have any questions on that, their questions on the web page on YouTube, on the chat. Is there any of you who wants to take Ashraf's question? Mohammed, Kathleen?
I can start. Yeah. Thanks, Ashraf, and thanks, Diane, for your comments and reflections. First of all, I would like to go first to Diane intervention and kind of drawing on the similarities between similar contexts and what it means to be in isolation. And because this is also the theme of this webinar. I think what we found out in our research that siege or blockade created kind of a different lens to see the dramatic situation for a chronic emergency, which has been going there for many decades, actually. It has been exacerbated since the siege, which was enforced in 2006, but the crisis has always been there, Gaza being under the Israeli occupation. So I think we can see a reflection of all of these aspects in the themes which we captured. For example, if we think about the sources of information, the reliance of people on internet, for example, or on the social media reflect what would be the situation of, like, for a group of people living isolated from the outside world, internet becoming a space for them to interact and to find information. So through these kind of lenses, I think we had a different kind of reading of all of our findings. So blockade in a way, and the lack of movement, or the kind of the impossibility to live in a normal situation, let alone being in the middle of a pandemic, provided a different way of looking at the situation in Gaza. For example, think about the restrictions, the regulations. They all have different kind of flavor in the context of the blockade, because I mean, people in a way are accustomed for not traveling abroad. Most of the people haven't left Gaza in their lifetime. And I remember in conducting one of these interviews, when I asked these questions about how does this restriction of movement have been affecting you, people were saying, no, I mean, we don't travel. But when you go deeper, asking about, for example, how it impacted, for example, the medical care supplies, the fact that maybe other people in the family who suffer from kind of diseases which cannot be treated inside Gaza, they start to reflect on what has been normalized. I mean, the fact of being in isolation and not being in contact with the outside world. So I think it was important to draw on these kind of similarities. Thanks, Dan, for bringing these aspects. I think it's always enriching to look at the similarities and differences in such context. And then I'll go quickly to Ashraf's question, and then I'll give it back to Kathleen. I think for the question, I'd like to answer about the question about the political affiliation of the participants. I think the fact that we were doing this research online and kind of made it even more difficult to ask about people political affiliation and to have this kind of disaggregated point of view about who's thinking what. But we imagined, I mean, we tried through our sampling strategies and sampling methodology to make sure that everyone is included in the as part of the discussion. And that's why we had these kind of different messages about people approving what's going on and people disapproving it. Of course, this also answers to your second question about the ethical dilemmas and the fact that if we are doing this research face-to-face, probably we don't have to deal with many of these kind of sensitivities, and we would dig even deeper in answering our research questions. I hope I answered your question. Back to you, Kathleen.
Thanks, Mohammed. Yeah, perhaps just very quickly to add on the issue of ethics of doing remote research. I mean, all of the ethical challenges that would come with doing this work in person are almost even more exacerbated by the nature of doing it online. Perhaps specifically around two areas, around being really sensitive around data protection, and also, I mean, as you were just saying, Mohammed, you know, perhaps the answers would have been different if we'd been there in person, and something that's so difficult when you do this research, not in person, but by phone, is not being able to sort of immediately follow up or put people, you know, extend contacts or networks of contacts for people depending on the kinds of things that they share with you. And also obviously the concern of adding pressure on people at a time where COVID is obviously adding immense pressures to people's lives already, to then ask them to take part in research on top of that. And just maybe to flag quickly 3 ways that we tried to mitigate that to the best extent possible. I mean, this research was really designed to feed into the humanitarian response to COVID, and we were working, and we have since the publication of the study been working with various different NGOs and organizations to really try and make sure that the findings are used and are useful in shaping the response moving forward. We also worked with a lot of different community partners in the formulation of this study, and that sort of acted as a bit of a safeguard for us in case there were sort of any difficult disclosures during the research process. And as I said at the start, all of the team working on this study do have sort of extended networks in Palestine, so we felt quite comfortable that we would be able to follow up. And finally, just with our methods, that was really why we drew on the diaries and also the WhatsApp voice notes as 2 methods that we thought were quite unintrusive at this time, because they both gave research participants the scope to respond to our questions in the ways that they felt comfortable to do so, but also in sort of timeframes that they felt confident to do so, rather than just sticking to interviews. Thanks.
Thanks, Kathleen. Thanks, Mohammed. We have a question. We have a couple of questions from Andrew Geddes. Ashraf, you show vaccination levels are low, but what about cross-border workers moving between Gaza, West Bank, and Israel? Do they get it from Israel? And then we have another question for Kathleen. Mohammed. Could speed of access to vaccination have the potential to exacerbate the effects that the report identifies? Ashraf, if you wanna.
Yes, sorry. The question was about the vaccination in Gaza and how they came from Israel, or
So the question is, you show that vaccination levels are low, but what about cross-border workers moving between Gaza, West Bank, and Israel? Do they get it? Do they get the vaccination from Israel?
No, not from Israel. Actually, the vaccination come to Gaza by donors from China, Russia, and EU. And the Palestinian Authority in West Bank sometimes buy this vaccination and provide Gaza with the vaccinations. But I would say that there was kind of politicization in the vaccination provision to Gaza. Now, Israel tried at the beginning of the crisis, tried to politicize this issue and prevent provision of vaccination to Gaza. And some Israeli officials said that Hamas should release our soldiers who were captured in the last war by Hamas soldiers. So some of them said that no vaccinations without release of these soldiers. But after practicing some humanitarian diplomacy from United Nations, Qatar, and other countries who negotiated with the Israelis and tried to convince them that it is a humanitarian issue, it is not a political issue, and now Israel allowed to provision of this vaccination to Gaza. Despite it's slow, the vaccination come to Gaza on doses, and the main provider for the vaccination is the Palestinian Authority in West Bank. So that's it, not from Israel.
Okay, thanks. Kathleen, Mohammed, you wanna take Andrew's question? Could access to vaccination have the potential to exacerbate the effects that the report identifies?
Mohammed, shall I start?
Yeah, please.
Yeah, it's a great question. I mean, clearly access to vaccines is critical in terms of curbing the future spread of the virus. But I think what the report really highlights is that so much damage has already been done by COVID so far in structural ways, that regardless of the vaccine and how COVID continues to deteriorate in this context, there's so many other different levels in terms of the sort of socio-political and economic impacts that the virus has had so far, that it's going to take quite some time for those to be rebuilt. Mohammed, do you want to add?
Just, I would like to echo what you said, Kathleen, and the fact that the blockade resulted in a lot of vulnerabilities, which put the population in general in even more harm. I mean, just imagine if, for example, Gaza have the infrastructure for the proper internet, which until now is prevented due to the Israeli occupation. Just imagine if there are available employment opportunities for the population in Gaza, and they are, for example, and we don't have 40% of the population being unemployed. Just imagine how this would be reflected in the situation of the pandemic. So I think, as Kathleen said, a lot of harm has already been there, but I think lots of people think of vaccination as the end of the problem, but I think in a context like Gaza, where vaccination become kind of a political bargain, this is I think we cannot really rely on this hope of getting everyone vaccinated, because I mean, so far we've been following the news about the vaccines, and it's all about not only the Israeli occupation, but it's also about regional powers kind of practicing a form of I don't know how to put it, but kind of political leverage through donation, which makes the situation is even more difficult, far more difficult. I think one of the key messages that the report is trying to send is that there is a lot of vulnerabilities that are there due to the current pandemic, but we have to attend to the causes of these vulnerabilities, and these causes can be lifted if we don't have this long-lasting blockade of the Gaza Strip. The fact that people cannot move freely in and out, the fact that there's unemployment rates that are very high, and the fact that Gaza is very overcrowded. All of these aspects make a perfect recipe for a disastrous situation when there is a pandemic, I think.
Thanks a lot. There is another question by Annie Okashish. She's for you, Kathleen, Mohammed. So if you want to, you are in a row. I'm going to take it from here directly. There is a vacuum in terms of efforts to shape policy, although many actors involved in the response in Northwest Syria and Gaza, for example, are the same. Why do you think this is the case? And how do you think the humanitarian architecture can enable local actors who, based on the presentation, appear to be more successful in mitigating the impact of COVID-19 on communities. How can these local actors carry out their work thanks to the humanitarian architecture? How can they enhance the work of local actors? And I will abuse of my position of chair to ask a question to everybody, especially to Diane. I mean, I agree with everything you said. I mean, the official response, basically, I mean, what studies, empirical studies have shown is that the official response to COVID is often heavily based on constraining mobility, and it's shown clearly its limitations. And on the other hand, we see a divergence trend. On the other one, we see that the official response, which is bad. On the other one, we see the leading role of local actors that are actually compensating the deficiencies of this official response. Sometimes I wonder myself whether there is no a tendency of researchers like myself to romanticize the work of the the groundwork, the work from the bottom-up approach, let's say. So I wonder, what are the limitations and risks involved in the role of the local actor response, So anyway, Kathleen, Mohammed, if you wanna be the first.
You wanna go first, Kathleen?
Up to you.
I'd like first to comment about the humanitarian architecture and the fact what extent it was kind of enabling to the situation that is there in Gaza. And I believe here I'm going to bring kind of a critique about humanitarian system in general, being usually situated as something which is neutral, which is kind of partial, doesn't get involved into politics. And here we're speaking about a situation which is very politically charged at the level of the discourse, but also practically speaking. So I think it's in a way this came out as part of our research. For example, in the words of our respondents, they weren't relying a lot on the international actors or international humanitarian actors, and they saw their kind of role as being marginal, less relevant to the management of the crisis, although they are basically the ones who are putting money, I mean, inside Gaza. I mean, Gaza is not sustainable from a financial point of view by itself. It's thanks to the foreign aid that health and education is provided to the 2 million people living in Gaza. But the fact that the humanitarian actors usually distance themselves from getting involved into politics, I think this is a bit disempowering to the potential role of the humanitarian actors can play. And in this way, I see the humanitarian architecture as being one of the factors, as it is right now, as one of the factors which are deepening the crisis, unfortunately. What do you think, Kathleen?
Yeah, I completely agree. And maybe just to stress as well, and it goes to your question a little bit, Luigi, actually, but so many points throughout this study, it was really reiterated that any work, the sort of effective work that was being done within communities. It was being done by youth associations, by women's groups. It was, the people who were providing food for people who didn't have food. These were coming from within the local community. The people who were doing, trying to run campaigns on please wear a mask and, the importance of hand sanitizing. These were all coming from within the local community. And partly there's also a piece of this which is just about the level of distrust that's grown in the international community over time. And again, it precisely links to what you're saying, Mohammed, is that, COVID is the current hot crisis, but this is in a place that's been dealing with protracted crisis for such a long time now. And I think there's a very, my takeaway from a lot of the data collection that we did was a strong sense of abandonment by the international community, and this idea of the need for self-reliance to get through these kinds of situations. We didn't really get to speak about it in the presentation, but this is actually one of the sort of more worrying longer term implications of some of our findings, is that while on the one hand, many people explain to us this, this strength of sort of community solidarity, and that you rely on institutions within communities rather than the humanitarian architecture at times like this. At the same time, those ties are starting to break, precisely because of the kinds of restrictions that COVID is imposing, and because of the fears associated with contracting the virus, and people no longer wanting to necessarily go and see their neighbours or ask for help when it was needed. Diane, do you want to come in to the discussion?
Yes, thank you. I think it's a great discussion to have now about the humanitarian architecture and the sort of balance and cooperation between sort of international and local actors. And again, I think this has been said before in the discussion, but COVID-19 here is shedding light on pre-existing sort of power imbalance in the humanitarian architecture. And I think we're sort of saying issues coming back to the table, which had been, for example, discussed at length during the Humanitarian Summit in Istanbul in 2016. And we see that even if the sort of local actors are clearly, I think their role is clearly more valued in terms of the leadership they're taking, the sort of financing of community organization is not following. And so I think COVID-19 is really showing us this gap between this commitment on localization and what's now unfolding on the ground. And it's also putting, again, sort of at the forefront of the discussion, sort of who is leading the work on the ground are also the actors who are taking more risks in responding to the needs. It's also the case in Syria, where local responders, including clinicians, are responding to the needs of people in conflict-affected areas. And I think when Luigi, I think it's a great thing to actually say, okay, so are there limitations to this ground-up, bottom-up sort of initiative? Because first you do want to acknowledge that obviously also within this grassroots organization you have power relationships. That means that obviously you need this sort of fine-grained knowledge of the context to be able to operate on the ground. And if you think of international organizations operating remotely, if you're going to partner with local organizations, you need to have this connection with the field and be aware of power and more structural power relationships on the ground. And I think what Kathleen was saying is also key. I mean, valuing sort of local initiatives doesn't mean over-relying on local actors who are already stretched with the responses they have been developing before the pandemic. So I think there's, for instance, the issue of debts, people being having debts within their communities came across very strongly in your report, and it also came across a lot in my research in Lebanon. So I think these are really discussions that are important to have.
Thanks. Now, this is my question was obviously, on purpose controversial, because I definitely agree with your approach, since I contributed to the report as well. Anyway, and so I say I would call it over because we are 15 minutes beyond the deadline, and the end of this fantastic webinar. And I would like to thank everybody, Kathleen, Mohammed, Diane, Ashraf, and also special thanks goes to Kira and Giovanni and the staff at the MPC for making this possible, and for those who have been spending this 1 hour and a half listening to us. Thanks, everybody. See you.
Thank you.